So hello, everybody. My name is Natalia Szejko, and I'm a neurologist and member of the European Society for the Study of Tourette Syndrome. Yes, and I have also big interest in the treatment of cannabis-based medicine. And today we are very happy to have everybody join this event dedicated to sort of cannabis-based medicine and Tourette syndrome. Well, we already had one wonderful lecture by Elia, who is also here as one of the panelists. Today we will have a panel discussion regarding this topic. And I just wanted to encourage you at the very beginning to post your questions about this topic on the chat, because we have with us a great panel of experts. First of all, Professor Kirsten Müller-Vahl, who is a neurologist and psychiatrist working in Hanover Medical School. And as you know, she has a huge experience in this topic, both research and clinical. And she has been actually pioneer in this field. So I think we're very privileged to have her today with us. And as well as Elia, who is joining us from Toronto, Canada. And he's a child psychiatrist working there, but also having some patients, adults with Tourette syndrome, treated with cannabis-based medicine. And he actually, as you also know, maybe also published a number of pioneers' work on this topic, and I'm very happy to have him also today was one of the experts. And finally, it's maybe last but not least, but it's very important, and we are very happy to have with us also Peter, who is patient with Tourette syndrome, who has been treated with cannabis-based medicine. It's actually a patient of Elia. And it would be great to have your experience, to hear your experience on this topic. And so, like I said, if you have any questions, we'll be very happy to hear your thoughts and respond to your questions. But we will just start with our panel discussion otherwise. So I just wanted to first ask everybody, the panelists, about your personal and professional experience with cannabis-based medicine and Tourette syndrome. Like, can you share with us, how did you have this experience, and how this all started for you? Maybe we will. Well, for me, it's an easy question in terms of Kirsten for Kirsten, but I will still ask her. Can you tell us how this all started, and what is your experience? How do you find it helpful in treating patients?
Natalia, thank you so much for this kind introduction. And yes, the journey on cannabis-based medicine in Tourette started about 30 years ago, I guess. And it's all based on my clinical work here in my Tourette Center in Hanover. Because Tourette syndrome is a clinical diagnosis, and this is nothing I have to explain to you, but we all ask a lot of clinical questions to make the diagnosis. And one of the questions we routinely ask is there anything that improves, or is there anything that makes your tics worse? And when asking this specific question, the majority of patients answer that stress increases the tics, and that relaxation, something like this, concentration improves tics. Some patients answered, and when I use cannabis, then I have a significant improvement of my tics, and this is much better compared to all the drugs you ever prescribed to me. And this was something patients reported to me, and I had the idea, okay, this might be by chance, but it also might be an effective drug. And therefore, we started a systematic interview and survey asking all our patients, have you ever used cannabis? At that time, of course, it was illegal in Germany. And what was your experience? And in parallel, we asked for the use of alcohol and nicotine, so that we had something to compare with. And we found a similar result. The majority of patients reported about beneficial effects. And this was the start of several different studies we did since then. And the first study indeed was with pure THC. And interestingly, at that time, it was imported from the US. It was Marinol, because at that time in Germany, no cannabis-based medicine was available. And so we used capsules imported from the US and did our first research.
Great.
So ये जो red
Sorry,
ये
can
क्या
you? I just ask everybody
outside
maybe
right
mute.
yes
Sorry, I think Satha, if you can just mute yourself. If you have any questions, please just feel free to put them on the chat. Thank you so much, Kirsten. This was great. And how about you, Elia? Yeah, can you share with us a couple of words in your experience?
Yes, of course. I mean, very interesting to hear the details of Kirsten's experiences. My experience is very much parallel Kirsten's, but also follow Kirsten's, because Kirsten was the pioneer in this area, and I was familiar with her work. And I think, but I was, for me, I had just. It's interesting. It kind of very early after I finished my clinical training in 2009, and starting to practice independently. And then one of my very first referrals was specifically for that. So I hadn't yet heard about the things that Kirsten shared in terms of patients describing that it helps them and such. I was familiar with Kirsten's studies that she mentioned, the retrospective study and then the 2 control trials. So I knew about those because I was working in Tourette syndrome. So I was fairly familiar with the literature of all different treatments, including cannabis. But I knew the evidence was really just these handful of small studies that were all from the same place, which is Kirsten, and it was a young patient who basically had been followed by a child psychiatrist. And treated with the usual first-line treatments for Tourette syndrome, treated appropriately. But then as a young adult, had discovered, was in a party and a joint being passed around, and then she used it. And then when she went back home, her family said, "Oh, you don't have any tics. Where are your tics?" And then she put 2 and 2 together and realized it was the cannabis. So she wanted to use cannabis for her tics, and she did not want to use it illegally. She wanted medical cannabis. So this was specifically the reason she came to see me. And I was wary that I had no idea. I'd never used medical cannabis or anything. Didn't know how to access it or anything. I was just out of training, and also I was wary because this was a young person. This was a young adult, and I knew, I knew the work of from Kirsten, but it was limited evidence. It's not like there were tons of large studies or anything like that. And I knew about the risks of cannabis and that they are age-related, in particular the risk of psychosis. So I started telling her about the limited evidence and the risks, etc. And then she stops me and says, "Listen, I've gained 50 pounds on risperidone. I've slept through high school on clonidine. This is working for me. You're not going to tell me like the stuff you prescribe is any better." So it was compelling. And so together with her, we figured out how to do it. And we got through. At the time, it was a different way to get it. It was directly through our regulatory agency, Health Canada. And so, and she started cannabis and did very well. And then it was later that I started having these similar experiences that Kirsten described, where you ask patients what makes tics better, what makes tics worse, and consistently you'd hear patients saying that they've noticed cannabis makes their tics, decreases their tics. So I started gradually venturing in that, patients who failed multiple treatments and were struggling with significant tics, I would say, "Do you want to try cannabis?" And very often I would see improvements. Again, these are despite having failed multiple treatments and having pretty significant symptoms. So gradually started venturing more into this. One of my very early patients actually was Peter, who's here with us. So he's going to share his experience. Peter was asking me yesterday when we met, and I looked it up and I saw, wow, we met basically less than 2 months after I finished my clinical training. So he was also one of my very early patients. But I remember Peter at the time saying, this should be studied. This should be studied. Why? How come this is, not being pursued, not being given attention and such? So it was really with the encouragement of Peter and our experiences with our patients that we started pursuing this, and we've done some studies in it. And I think it's a very promising field. I think there's been, since then now, there's been quite a few studies, still most of them from Kirsten, but really from around the world. More different groups have been studying it, including us here in Toronto. But I think there's much more to be done still, and there are many questions that I guess we're going to get into that I think we should pursue. That there are still important questions that we should explore in the field.
Great. Yeah, this was amazing. Thanks a lot. And how about you, Peter? Yeah, it is sort of connected to my another questions, but maybe you can share with us a little bit of your experience as a patient.
Sure. I mean, mine obviously has been a personal journey. As a young child, I mean, I was born in 1965. So in the early 1970s, I think I was demonstrating, eye rolling, throat clearing, stomach, convulsions a little bit. My parents, I don't think there was correct me if I'm wrong, but not a whole lot of research in science back in the early 1970s. So they brought me to the doctor. They thought that might be some allergies and other things. But, as Elia presented in the other meetings, by my early youth, I think most of it went away, as I was in high school and stuff. It wasn't very apparent, my tics, which was good. It really only came about again in my early 30s, I would say. And to Kirsten's point, it's really stress, anxiety that I think brought a lot of that on in my adult. I was working at a pretty demanding role, a job, working 50, 60 hours a week, 2 young children at home, a wife, and the stress of all that, I really started to get some head shaking, shoulder rolling, different kind of tics, which became noticeable. I remember specifically in a meeting, somebody was presenting and I shook my head and they're like, "Oh, you don't agree?" And I'm like, no, it's okay. And, I started to sit at the back of the meeting because I didn't want people behind me seeing me shaking my head and stuff. So, I went to my family physician. He referred me to a movement disorder specialist, I think more treating Parkinson's, Huntington's, those kinds of things. Put me on different kind of medications, some of the ones Elia mentioned. But, the effect of those wasn't so great on the Tourette's, I would say, but it just made me so lethargic, just drowsy and like cotton in my head, really hard to concentrate, even on day-to-day work, and made me sleepy and stuff like that. So, I spoke to my doctor again, and we ended up, so lucky for me, I met Elia back in 2009, and, we tried a couple more medications and stuff like that, but then there was a test, obviously, to try cannabis, and so I was all open to try that, and the effects have been amazing. Like, it's really and none of the all the drowsiness and stuff that I had with the other drugs weren't present. I was able to function at work and with my family and everything else. So, but really, and I tried the THC and the CBDs, and definitely the THC is the one that works. The CBD did not really have any effect for me. So yeah, so that's kind of my journey. So.
Great. Yeah, thanks a lot for this perspective also. So again, I encourage you to put questions if you have any to the panelists. Actually we have like one question from Paula already. What do you think? Is it so that really cannabis-based medicine is always the last drug to try for treating tics? Maybe we'll just do the same sort of, or who wants to take this question? Maybe let's start. I see that Elia is kind of, maybe you've been nodding. So what do you think? Is this always the last drug to try?
I'm happy to jump in, but I was actually eager to hear Kirsten, but hopefully I can hear Kirsten. And I'd also like, it'll be interesting to hear Peter's opinion about this. But I'm smiling because, I said that I've been using it as a last resort with the patients. I would say it evolved over the years for me. So in the beginning, it definitely was a last resort. So it was only in patients who had failed, our main treatments, behavioral therapy, the multiple medication trials, and had very significant tics. So it was really only in these patients. But repeatedly, despite the fact that these are patients that failed multiple treatments and had significant tics, invariably, I would see dramatic improvements with the cannabis. And then over time, it stopped being a last resort for me because either on my end or on the patient's end, because some patients would be, already using it, obtained from the street and getting a lot of benefit from it. And as an aside, today in Canada, even recreational cannabis is legal, so they don't even need to obtain it from the street if you don't prescribe it. But anyhow, they were and finding it, and they're saying, no, this works for me. I don't want to. They hear the side effects about, from our antipsychotics, for example, and they're like, no, I don't want that. I'd rather just stay on cannabis, and if you follow strictly the guidelines and if you kind of very strictly stick to the evidence, it should be a last resort in the sense of that, we have other options that have much stronger evidence. However, in practice, when I think about it, I have, there is decent evidence for cannabis at this point. We need better and more evidence for sure, and it is not a panacea. However, I think there's enough evidence that it shouldn't be necessarily a last resort. It's again, our other treatments are not benign either. So that's one thing I want to say. And in some patients who have refused to try other treatments, that's been maybe the only thing that they've tried, and they're doing fine with it. This is all, I should say quickly, this is all in adults. So, in Toronto, I work at 2 clinics. I work in an adult clinic part-time, and I'm mostly in a pediatric clinic. In the pediatric tics and Tourette clinic, I think that's different because the first of all, the data for kids is much less, and second, the risks for kids it should be more concerning because the risk of psychosis is age related, and so there I've used it very few times with kids, but I have in adolescents but there it's really been a last resort. Yeah, that's my thought, but I'm be very interested to hear Kirsten and Peter, and also I'd be very interested to hear, Natalia, your thoughts on this question.
Thank you very much. Yeah, but maybe first I would like also to hear, Kirsten, what is your opinion?
Yeah,
is it always?
It's very similar. And indeed, it was a little bit a journey during the last years. And the more experience you have with the treatment, the earlier you are thinking of this. And because cannabinoids are often very well tolerated, and most of the patients have less side effects compared to antipsychotics, you are more open to discuss this kind of treatment. And in addition, but this is a specific situation here in our center, I think we are the center in Germany where most patients are treated with cannabis-based medicine, and patients who suffer from Tourette's who want to have this treatment often decide to come to my center because they know that I'm open for this kind of treatment. But in the end, here in Germany, we have a clear legal situation. This means that health insurances cover the costs for cannabis-based treatment independently, whether you use dronabinol, cannabis extracts, or even cannabis flowers, only if all standard treatment has been used before. So in other words, there is an option that health insurances cover the costs, but then it's similar to what you said, Elia, only as a last resort. So this is something patients have to know. When the patient says, okay, I can cover the costs by myself, I do not need support from the health insurance, then it's a matter of the patient's decision and my decision. And when we agree that this is the perfect treatment, and this is often in those patients who already used cannabis from different resources, from the street. And here in Germany, cannabis is legal only since a little bit more than 1 year. So a lot of patients used it illegally, but they can come to me and we can discuss it. And when they pay for the treatment on their own, it's possible to prescribe this. And this is something I do without trying habit reversal training or antipsychotics. In the end, when a patient says, okay, this is the treatment that is effective, and the treatment result is exactly what I want to, why should I try to find another treatment when the patient is already satisfied with the treatment he has? Then I can discuss with the patient, let's try whether there is a way to improve it. For example, not smoking, but vaporizing cannabis flowers, trying to also use oral routes of intake, thinking about the dosage, supervising the treatment, that the dosage is not constantly increased by the patients because it's unsupervised. So these are aspects I can add. And therefore, I would say supervised treatment is in any case better than unsupervised self-medication. But then I'm absolutely open to even start treatment with cannabis-based medicine.
Perfect. Thank you so much. Yeah. And yeah, Peter, do you have something to add as a patient? How about you? Do you think it could be like not last resort for some people?
I mean, for myself personally, I would have said it would have been my first choice had I known, right? Because I'd say I probably lost a decade of trying these other different types of medications that really, caused different side effects. I mean, even I had some growths and, just the drowsiness, having trouble getting out of bed, and at my desk in the middle of the afternoon feeling drowsy. I've never felt any of that with the cannabis afterwards. So for me, I would say it should be the first thing, but obviously for adults, for children, I mean, that's a whole other area, right? I mean, they may go away on their own, maybe habit reversal training things will work. Plus, I mean, the development of the brain, we don't know enough, until they get into their 20s, the effects there. But for myself, if I'd known that out of the gate, it would have been my first choice for sure.
Right, interesting. Yeah. So for me, I can say that it's a little bit similar to, I guess, all the panelists. I think that it really depends also on the experience of the patients. I a little bit echo with what Kirsten said, that really, some people, they really have personal experience with cannabis-based medicine, and then they just report that it helped them. And sort of, then I think it's helpful to listen to patients. And then second, really
Are
other
others
studies,
from
but
others
also
frozen?
especially in males.
Sorry, Natalie, you froze. Can you repeat maybe past
Hello?
15 seconds or something?
Can you hear me now?
Yes, we can hear you now. Can you
Sorry.
repeat the
No, I was just
last
saying that I think it could be also helpful, in the trial Canetics, Kirsten's trial, she demonstrated that it's really helpful in males with ADHD, especially and tics. So I think it's also like a valuable suggestion as far as it goes, to the group of patients that could benefit from this treatment. But yeah, at the end, I agree that it's helpful to listen to patients' perspective and tailor sort of well, a little bit do like a personalized therapy. Yeah, that's my opinion. But we have a number of further questions from the audience. So first, it's a little bit related to what was mentioned before. So when it comes to the risk of psychosis related to cannabis use, do we know whether cannabis truly causes psychosis or schizophrenia, or if it primarily acts as a trigger for people who already have an underlying predisposition? Yeah, maybe Kirsten, what do you think? So really, is cannabis, could they cause psychosis in all people or only in those who are predisposed?
So I think it's important to differentiate between psychosis as a kind of an intoxication. This is something we know for all legal and illegal drugs. If you are acutely intoxicated by a drug, and this is similar with cannabis, you may have a short period of acute psychiatric symptoms, including psychotic symptoms. But this is, in most people, not really a problem because it comes and it goes relatively quickly. The more important question is regarding psychosis as a form of a chronic psychiatric disease, so in form of schizophrenia. And there, at least my personal opinion is, and this is absolutely correct, what is said in this question, that then cannabis may act as a kind of a trigger. So in other words, you will not develop schizophrenia when using cannabis, when you have not this kind of predisposition. There's a lot of discussion on this topic, and I'm 100% convinced that in the past, people often judged that when a person used cannabis and developed a psychosis, that it's not only timely related, but there's a causal relationship. And this is definitely not correct in all cases. The only robust data we currently have from the literature is that people who are very young, and this is before puberty, and who use high amounts of cannabis with high THC content, have an increased risk to develop a psychosis in form of schizophrenia. This is the robust data. All other data is less clear than a lot of people think. And therefore, I believe that the research investigating the relationship between cannabis use and psychosis is heavily biased by aspects we all discussed in the past in relation to cannabis and cannabis legalization. And there's some new data showing that there is not such a close relationship as some people thought in the past. So in other words, for me, it's not a strong argument. When there's a patient and he suffers from a disease, then you always have a risk when you start a medical treatment. There's no drug without any side effect. And therefore, I would say when there's no other option for treatment or other treatments are ineffective or not well tolerated, I think the risk of psychosis is not that significant that you shouldn't start this kind of treatment. But you should ask your patient whether he or she has had a psychosis in the past and whether there's a case of schizophrenia in the close family. These are important aspects, definitely.
Mm-hmm. Thank you so much. Yeah, these are very important points. And sort of maybe related to this, and then I will ask also Elia about his experience, but I wanted to ask Peter, how about your experience? Did you experience any side effects of cannabis-based medicine? And yeah, how was tolerance of this treatment for you?
Yeah, I mean, started slowly, the dosing and stuff. So I can't really say there's been very many side effects. You know, if I experimented with different dosing, I mean, if you took a lot, I mean, you could feel a little bit of drowsiness, but I would try that like in the evening before bed to see. But no, I mean, if you do dosing a little bit throughout the day, way better. Like I said, like from the medications that I had, really no side effects and no psychosis, any of that kind of stuff either. So just a better quality of life, I guess, would be the side effect.
Perfect. Yeah. And Elia, you as a psychiatrist also, as Kirsten, in this group, what do you think about this issue? Obviously, a lot of people are concerned about cannabis-induced psychosis, right? So what do you think?
So my views are very similar to Kirsten's, but a little bit more on the cautious side, I would say, when it comes to the issue of psychosis. I agree. Kirsten puts it very well to differentiate between psychotic reactions as an adverse effect versus developing a chronic psychotic disorder like schizophrenia, which doesn't go away even after you stop the cannabis. Excuse me. And absolutely, as Kirsten said, all of our medications cause harm, okay, or have the risk of causing harm, and in its various forms. And I do think that one of the possible adverse effects from cannabis is psychotic reactions as an adverse effect. And I've seen it. Thankfully, it's not very common, but it's not extremely rare, in its various forms. So, some people might say, I'm feeling more paranoid, but they're aware of this, or they might say, I'm more aware of people noticing me, things like that. There might be more social anxiety, or there might be outright psychotic reactions, which I've seen where people develop delusions or even become manic. I've seen these reactions. And in pretty much all of those, we stop the cannabis and that resolves. Usually immediately it resolves. Sometimes I've had patients where it took a little bit of time, but eventually it resolves. And that's different than developing a chronic psychotic disorder like schizophrenia. And that one is what's more concerning, because you can have bad reactions from any drug as long as they're reactions that stop after you stop the drug and they're reversible and no long-lasting harm, then it's okay. But it's concerning, the idea that a harm that can stick with you. And that one comes from the pediatric literature, but specifically it's the cannabis abuse literature. So, and that one is age-related, and there's all sorts of confounders, as Kirsten says. If you have a 12-year-old that's smoking cannabis daily, well, there's a lot else going on in this kid's life in addition to smoking cannabis daily that could it's probably playing a role in terms of them having risk for psychosis. Having said that, and so it's all epidemiological data, which comes with a lot of confounders. Having said that, it's been a fairly consistent finding in different trial designs. There's dose response relationships, there's plausibility. So everything is I think points enough to the idea that abusing cannabis in young age increases risk of psychosis. Now, what about treating using medical cannabis in a controlled fashion in kids? Does that elevate the risk of psychosis? I don't believe that we have enough data there at this point, unless, I'm not fully aware of all of the data, but for me, I'm wary, because now, even though it's not abuse, it's control, it's medical, but it's still, it's a child taking cannabis every day. And, I think we have to be very cautious there, I would say in most patients that have used cannabis, the experiences have been more positive than negative, but it's not a panacea. I've seen patients where cannabis did not work, but also patients where there's been enough of negative reactions that they couldn't continue it, and including psychotic reactions. So we have to be careful, not just like with cannabis, with any drug, we should be careful, basically.
Yeah, great comment. Yeah, we're going to come back to this too, but I just wanted to also sort of, just cite, because there is a very nice comment by a patient. I don't know, your nickname is E. coli, but the patient, like this person, like you wrote that I'm a patient too, and I completely agree with Peter that all the other meds only made me very tired and gain weight a lot when it finally shows any result in reducing tics. But with medical cannabis, I had never any side effects. Never got any high feeling, never got stoned or hungry. So even during working time, medical cannabis works better than all psychopharmaca than I had used in all my life. For me, it helps me best with very painful dystonic tics than the vocal tics, sorry. But my experience is also that, for instance, Sativex is not working like medical cannabis with high percentage of THC using by vaporizer. So yeah, great comment. Thanks for sharing this with us. And I just wanted to say that, yeah, this reminds me of some of my patients who actually have painful tics. And here I think that cannabis-based medicine could be really helpful. And as well as if these are focal tics, botulinum toxin for some people. Yeah, and yeah, related maybe to this comment, yeah, what do you think? I mean, we know from the literature, but what are the most commonly used cannabis-based medicine for treatment of tics, and what are the most helpful? Like, what do you recommend? Maybe we start again with Kirsten.
So I would say currently we do not know, unfortunately, because there's no data, there's no study at all comparing different cannabis-based medicines in Tourette's. And there are different aspects. I think we all agree that it's THC. Peter also said it's THC, not CBD. So I would say we don't have to investigate whether CBD is effective in Tourette's because it is ineffective. I think we do not need a study on that. But what we do not know is whether Sativex or other cannabis extracts are better or worse compared to cannabis flowers. But we have some reports from patients, and these reports, at least here in Germany, are limited depending on cost coverage by health insurances and depending on the legal situation. This changed in recent years in Germany. But in the beginning and the journey that we were allowed to prescribe cannabis-based medicine in general started in 2017 here in Germany. So it's now 8 years. Now we are more flexible, but in the beginning we had only few drugs and only few drugs were covered. Cost of these drugs were covered by health insurances. So now we have more options, and I always try to motivate my patients to try different cannabis-based medicines, to use different route of intake. So to compare oral drugs, we have not only oils, but also we have capsules, we have mouth sprays. So there are different options. Only recently, cannabis extract that can be vaporized came on the market here in Germany. So there are a lot of different options. And my guess is the most effective drug is inhalation. And what I do not know whether there's a difference between inhaling flowers or extracts, because this started only recently that a company offered an extract for inhalation. So far, we haven't had that option. We are just starting a survey among our patients. We now have more than 200 patients treated with cannabis-based medicine. And we just have a student who decided to work on this. And we exactly want to ask this question: what kind of cannabis-based medicine have you used ever in life? And what is your experience? And in the end, we want to ask the patients, what's the best option for you? And my speculation is that most patients will ask cannabis flowers.
Yeah, great. That's also what I expect, actually, and my experience too. But yeah, question for Peter. What kind of cannabis-based medicine did you use? And was it natural cannabis or synthetic form, do you know, maybe, of THC?
Yeah, I think early on, Elia prescribed some of the synthetic ones. I've tried different ones of those. I can't remember back then if they had some effect to help, but it's really the natural cannabis that I find is most effective. I mean, personally, I've used oils. I've smoked it in a joint. and rather I use a vaporizer. So when I was, I retired recently, 2 years now. So obviously a little bit less stress in my world then. But when I was working, I typically was relying on the oil. It was probably the easiest one to dose. So, I take some in the morning before, after getting up, take some midday and then at night. And I really kind of just kept it through my system and never really felt the highs, but the effects were positive in terms of reducing it. As I retired, like any it is a medication in a sense. I don't, luckily for me, I don't take any other medications. So I thought I'd try and reduce the amount of medications, do more mindfulness and meditation and, things like that, which help as well. So, I don't do the oil 3 times a day like I used to. If I really feel stressed and stuff in the evening and I want a really good sleep too, vaporizing obviously is instantaneous, right? I mean, within a minute, you vaporize and you feel the effects and the calmness and the relaxation. Obviously, oils or capsules or edibles, depends on what you ate. That you got to digest it. It can take sometimes a half hour, an hour. So you don't get that instant effect. So that's a little bit of, the way I've experimented and worked with those. So.
Perfect. Great. Thanks for this comment. And also, again, the patient, who's joining us with this nickname, E. coli, he or she, I apologize, I don't know, but very interesting comment that inhaling by vaporizer is also the easiest to dosage. And we're going to talk about the dosage in a moment. But what do you think, Elia? Do you have any comments in terms of your preference? Like, what do you think is the most suitable cannabis-based medicine to use in patients with tics?
Yeah, again, similar to the comments that have been shared already. And it's nice to see, by the way, it gives you some confidence when, we're different continents, different contexts and everything, and we're having very similar experiences. As Kirsten put it, there's the compound, and then there's the administration, the form. With regards to the compound, I think there's no doubt it's THC. And there's a lot of evidence in that supports that. First and foremost, when so many people are describing their experiences from using cannabis recreationally, let's say at a party, and the tics go down, well, that product is basically THC. There's no CBD in that product, so that's the first thing. And when we started using it in Canada, medical cannabis, there was only one option available through Health Canada, and it was a THC option. There was no other option. There was also, there's the study from Kirsten that was published in 2019, where they surveyed the patients they had, and it was very clearly it was THC, and there was a preference specifically for cannabis over the other products, the pharmaceutical products. And then we also did a study ourselves. And the reason we did the study comparing THC and CBD and combo and placebo is because we had applied for a grant to use cannabis for tics. But at the same time that we applied for a grant, the medical cannabis system in Canada changed dramatically, where it was no longer Health Canada providing it. Health Canada didn't want to continue providing it. So they started licensing different companies to provide it. And all of a sudden, in very quick time, there were dozens of these companies, each producing dozens of products. So all of a sudden, it wasn't just the single THC product that Health Canada used to provide. All of a sudden, we had pure THC with all sorts of strengths and CBD with all sorts of strengths and the combinations of them. And then, so when our grant was not successful, and one of the main comments was, well, what formulation are you going to use? What compound are you going to use? THC, CBD? How do you know which works best and such? So it kind of forced us to do a study where we compared the different products. It was a small single dose study, meaning you just took one dose and then you were monitored for several hours, blood levels checked and everything. And again, what was clear from that study was THC had nothing. Like there was no signal, there was no relationship between the blood levels of THC and tics. And so I think that the literature at this point and our overall body of knowledge in this area is pretty compelling that the effect comes from THC, not from CBD. But it's unfortunate we still have to say it, and we have to say it strongly, because CBD gets a lot of hype. You know, the wellness industry, it's all about CBD and whatnot. And I've seen, it's amazing to see things shift so much, where in the past, cannabis, people be like, oh, really, cannabis and such. And we're talking in the past, not that distant past, like 15 years ago when I started with this. But now I'll see parents who are giving their kids, 15 drops of CBD oil a day because of, it's good for you kind of thing, because they have a nervous system thing. And it's like, no, don't do that. So we have to be careful with that. The one thing I wonder in the back of my mind, because we use, for example, we've compared THC and CBD in equivalent doses. What if the doses are not equivalent? What if we need much higher doses of CBD? So CBD, for example, is effective in some rare forms of epilepsy, in much, much higher doses. But first of all, it's a completely different thing. I don't know why it's comparing. It doesn't mean because they're effective in this rare forms of epilepsy, they're going to be effective in tics. So it's a completely different thing. That's one. Second, if we think about the mechanism of action, it's very different, the mechanism of action. So I don't think there's reason to pursue CBD. I would agree with Kirsten. The only thing to consider, like research-wise, would be if people want to try high dose, and then this is, we can put that to rest completely in terms of CBD for tics. So that's in terms of the product. In terms of the compound, in terms of the formulation, in Canada, what we've used has been dependent on what's legal, and that's changed over the years in terms of what's legal. So, for example, only recently, a few years ago, oral cannabis became legal, and before that was only inhaled flower, which is interesting. So we've tried things as things have evolved, and in theory, I would say, it's best not to expose your lungs and to take it orally. And if you're using the same compound, the THC, it should have ultimately similar effect, whether you take it by inhalation or by mouth, in theory. In practice, there are differences. Ultimately, is THC going to be more effective? If you inhale it, there's an immediate spike, but then it doesn't last very long. It leaves your system quickly. Whereas if you take it orally, it's much slower to go into your system, and then it lasts longer. Is one more effective than the other? I think this is where, as Kirsten said, we don't have enough studies to compare directly that way. And it's worth, so in the meantime, it's about people trying it out. The last thing I want to say, and sorry, I've been going on for a while, but just to speak to the pharmaceutical cannabinoids compared to cannabis. Yes, especially early on, I would want to go with the pharmaceutical cannabinoids that are prescription-based rather than going to cannabis. And because, it's still closer to something medical as opposed to using, a flower, a drug with all the stigma around it. But consistently, like Kirsten has found in her study that was from 2019, and what we found, by asking patients, is consistently, and what Peter has shared in his own experience, is there is some benefit from the pharmaceutical ones, but for whatever reason, the cannabis, the actual cannabis flower is what works the best.
Perfect. Thank you so much. This was a great comment on this topic. Yeah, and how about the dosing? Yeah, I know that we talked about several different cannabis-based medicine, but yeah, I don't know. For example, do you have any recommendation in terms of the dosing of if you want to start medical cannabis, Kirsten?
So we talked about THC and CBD, and when we talk about the dosage, then you should only look at THC. When you have an extract, depending on whether it's a balanced product or THC dominant product, you always have some CBD with it. But some people argue that there's a so-called entourage effect, and the CBD that comes with THC may improve efficacy and may reduce side effects, but this is not 100% clear. But when you start a medication and someone is cannabis naive, I would recommend to start with an oral product. You can either use a mouth spray, or you can use oils, or you can use capsules. There's no difference. So I simply ask the patient what he prefers. And then I would recommend to start with 2.5 milligram THC per day. When the patient is very old, when the patient is very young, when the patient takes a lot of other medications, when the patient has a lot of other diseases, then I would go down perhaps to 1 milligram THC per day. And then I would slowly up titrate. This causes a tolerance, and this is wanted because it reduces the side effects. And then I up titrate, let's say, starting with 2.5 milligram THC per day. I up titrate every 2 to 3 days by 2.5 milligram. Most patients have a very mild effect at 5 milligram, but most patients definitely have an effect with 10 milligram. And on average, I would say most patients use between 15 and 25 milligram THC per day. But there are also some patients, because cannabis-based treatment is always very individually, there are also some patients who use 30 or even 40 milligram THC per day. When you want to start with cannabis flowers and the patient is used to it, then you simply can ask the patient, what are you using there now? But you should be aware that the cannabis, at least here in Germany, that is on the black market, is in most cases at low quality. And you should not think that in any case it has 20-25% THC content. And therefore, when it comes from pharmacies, I always recommend to reduce the dosage so that there's no overdosing in the beginning. And then up titrate instead of down titrate. But when there's someone cannabis naive and he or she wants to use flowers, I would start with a low dosage. I recommend to use THC dominant flowers with a THC content of about 20-22%, and then start with a low dose of 10 to 15 milligram cannabis flowers per day. And of course, we always recommend to use a vaporizer. And then it's the same, slowly up titrate, see what happens, and then decide in a second step how many intakes you need per day. Often it's 3 or 4 intakes, but I also have patients who use it 6 times, 8 times per day. And then you also can decide on the total dose and on the single dose at each intake, because it mustn't be the same. You can use it in a higher dose, for example, in the evening, and in a lower dose in the morning. And this is very individually.
Perfect. This is very helpful. Yeah. How about you, Peter? What doses of cannabis-based medicine do you find helpful for you? What is your experience?
Yeah, I mean, when I was dosing throughout the day, it was probably about 7 milligrams, in the morning, and then in the afternoon, at night. So that's like 21, I guess, over the course of 24 hours. Now, if I'm not taking it regularly all the time, if I feel very stressed, and it's at night, especially going to bed, where the mind's racing and the tics come out. A couple hours before bed, I might do 20 milligrams, right? So I know I'm going to bed, and I sleep very well through the whole night. So like Kirsten said, you can play around with it. So before bed, I know I'm not driving anywhere. It wouldn't have any effects if I got drowsy. I would do that. But through the day, it was just more, I was doing about, I think, around 7 milligrams a few times, and never had any drowsiness, any side effects like that.
Interesting.
And if I do smoke, it is with a vaporizer, would be the preferred way. But also, mostly it's the oil is probably the one I use the most. So.
I see. Okay. How about you, Elia? Like, what is your experience? What dosing do you usually recommend?
So it's actually almost identical to Kirsten. Like, so in a way, I don't have much to add. The only thing I'll say is I tend to be a little bit slower with how frequently I go up. I tend to give it maybe a week between those increases. But I'm not saying one is better than the other. It's just this. My general approach is not just with the cannabis, but with any medication. Tend to be more on the conservative side. But with cannabis also, because I think of it as being absorbed by fat stores in the body, and so you want the initial period it's being sucked up by the fat stores. So I want these to saturate, and then you get more reliable, steady blood levels. But this is more theoretical than anything else. The other thing I want to say is as Kirsten said, it doesn't have to be that all the doses are equal throughout the day, and you can have a higher dose in the evening. But I just want to say that interestingly, I've had patients where it's the opposite. We've used lower dose in the evening when they did. The reason being they had no issues with sleeping, and they didn't need it to decrease their tics in the evening. But because the effect of cannabis is kind of more active when it's there, when it's present, that they actually more wanted the effect to be there in the day. So basically, just to say that it could go either way, depending on the patient. And then the last thing I'll say, yes, it's interesting because when inhaled, the patient can self-titrate because immediately you get both the positive and the negative effects. So you know how much to go and when to stop when you inhale it, whether it's vaporizing or other inhaled forms, preferably vaporizing, and that can be a guide. And it's until a few years ago, definitely the way to start with us in Canada was with inhaling. But now that we have the past several years that the different oral extracts are available, then that's definitely been my starting is with oral. But it is, I think, a question still, like comparing the two, and a lot of patients might have a combination of the two, like for immediate effect, they might, basically exactly like Peter shared, might have the extract for the day, and then in the evening might inhale to get a more immediate effect.
Interesting. Yeah. Thank you so much. Yeah. So now, yeah, we've been talking a little bit about it already. So I mentioned this study by Kirsten, which kinetics, in which it has been shown that in particular in males with comorbid ADHD, maybe, nabiximols at least could be helpful. And then my personal experience that some people, in addition to tics, have some benefit for treatment of pain if there is a pain related to tics, or it could be helpful for coexisting anxiety or sleeping problems. So what is your experience with comorbidities? We know that around 80–90% of people with tics, in particular Tourette syndrome, they have comorbidities, most commonly ADHD and OCD. So do you think that these can improve also, and which ones in particular? And again, do you recommend any cannabis-based medicine in particular? Again, maybe we start now with Kirsten.
Our study, our kinetics trial you already mentioned, Natalia, unfortunately did not show that comorbidities improve. There might be different reasons, and as you mentioned, we used nabiximols as an oral mouth spray, and we already discussed that there might be differences between inhalation of cannabis flowers and nabiximols regarding efficacy. But my clinical experience is indeed that a lot of patients report that not only their tics improve with cannabis-based medicine, but also some of the comorbidities. And the most often comorbidities I hear from my patients that improve is comorbid ADHD. ADHD and cannabis is a very interesting story, and there's only very, very few data. But we all know that a lot of people self-medicate with cannabis. And I also have some patients without Tourette's, only with ADHD, that I treat with cannabis and cannabis-based medicine. The second, what I often hear is that sleep improves. And I have also some patients who report an improvement of other comorbidities, including OCD, depression, anxiety, self-injurious behavior. And I also have patients who report that their premonitory urges decrease. So it's not only the tic that can be counted and seen by others, but people also report that the urge to tic goes down and that it's easier to suppress tics when using cannabis-based medicine. But there's no robust data. All reports, all surveys exactly tell this story, that there's also an improvement of comorbidities.
Mm-hmm. Yes, thank you so much. Yeah, how about you, Peter? I'm not sure whether you have any comorbidities, but any other symptoms that you notice that are better, maybe in terms like since you started this treatment?
Yeah, I mean, nothing specific. I mean, I would say though, like, when there's a lot of stress things going on, the mind racing, you're thinking about this, how am I going to fix this, or what's going on with that? Like, I might go start thinking about different things. It does create more of a relaxation and be able to focus more, I think, than as much of the mind racing, if you will. I don't know if that falls in under any of the, but yeah, that would be the only thing. I think it's, just more calmness, I guess.
Great, thank you. How about you, Elia? What is your experience about comorbidities?
I would say overall similar. In general, the patients in general report improvement in the various comorbidities mentioned. I've almost never used it though specifically to target the comorbidities. It's always been to target the tics, and then as an additional effect, often there is improvement in comorbidities. We don't have great data in terms of cannabis for OCD or for ADHD, but I think it's interesting to pursue and see. And then, is there a difference with the effect of cannabis on OCD or ADHD that is outside of the context of Tourette syndrome versus the effect on OCD or ADHD that is in the context of Tourette syndrome? I think these are interesting things to pursue down the road.
Perfect. And yeah, maybe now we have one comment and a question related to this, and maybe I will now ask Elia first to comment on this. What are the risks for us patients, because this is again a question from one of the patients who is joining us, that have ADHD in addition to Tourette syndrome and using stimulants during the working hours, because only this is accepted by the employer when there is overlapping times with cannabis. And here the patient is sharing that I'm still waiting until the retard stimulant does not work any longer until I dare to use the medical cannabis, or during days of not using stimulants, but only cannabis. Yeah, what is your opinion about this?
Again, here I'll be interested in hearing Kirsten, but I'll share. As a general principle, the goal is to have as little medication as possible, both in terms of number of medication, in terms of the dose of the medication, in terms of how long you use it for. So I'd rather the patient not be on cannabis and something else, or like anything and any agent A and agent B, etc. So in this case, it's specifically the question is cannabis and stimulant. If we're going to use cannabis, I might try to see, okay, can we get away with just using cannabis and not using the stimulant? So that's one thing. But if we can't, because the cannabis doesn't help the ADHD much and it's the stimulant that helps, then I don't see myself a contraindication between the two. The one thing though, as I'm looking at the question, is because it might be more because the employer doesn't because of work reasons, they cannot have cannabis in the system. So maybe that's a different situation to be aware of. But other than that, I don't think they're contraindication to use together, other than the fact that, in general, the more drugs you have, the more chance of side effects from them. Even if one causes a little bit of a certain side effect and the other one also causes a little bit, the combo of the two might increase it more as a general principle. But otherwise, it's not like I've specifically avoided these two, this combination.
Thank you. Yeah, what is your experience, Kirsten? What do you think about this issue?
I also see no contraindication to combine these. I completely agree with Elia that one should try to use monotherapy, but when the combination is superior, why not using the most effective combination of drugs? And luckily, THC can be combined with several different drugs because there's not much drug-drug interaction between all drugs and THC. This is completely different when using high-dose CBD treatment, but with THC and even high-dose THC, there's not much drug-drug interaction. Of course, you can increase sedation, dizziness, drowsiness, things like this, yes, but no other critical aspects. And therefore, I also have patients, most patients decide to stop stimulants and to use cannabis only. But I also have a few patients who use a combination and find this most effective. And then I see no reason not to do this.
Yeah, that's also my experience. And I have never seen also any side effects with the combination of both. Yeah, and there is actually a question from Peter. Yeah, he's asking, is there any data on the use of indica versus sativa strains? Maybe Kirsten, what do you think? What is your experience also?
There's no data, of course, because there's more or less no data on cannabis flowers in Tourette's. But honestly, there's in general, no robust data showing that there is indeed a difference between indica and sativa strains. Why? Because we are talking about THC and CBD and perhaps minor cannabinoids and other ingredients in cannabis. But what does tell us indica versus sativa? It tells us that the leaves of the cannabis flower looks different. So it's a term that comes from the biology of the plant. And it does not tell us anything about the ingredients of the cannabis plant. So in other words, although all people worldwide believe that there's a difference in cannabis indica versus sativa, one is more activating, the other one is more sedating. This is not based on scientific knowledge. So in other words, I'm not convinced that there's any difference in efficacy and safety between these two different types of strains. I have a lot of patients who prefer strains belonging to the indica or the sativa group, and I'm absolutely open. When a patient wants to use this strain and believes it's better effective compared to another one, then I have no problem to prescribe this. By the way, at least here in Germany, most of the strains are hybrids. So in other words, they are a mixture of both, and only very few strains are definitely indica or sativa.
Yeah, it's the same in Poland. You, Peter, do you have any experience like that you want to share, or did you try it also mainly hybrid?
Yeah, I mean, initially, when it was just medical cannabis, it was a hybrid. But obviously, since it was legalized, I think all the way back in 2018, 2019 in Canada, there's been a proliferation of obviously a lot of different kind of drugs, and they have sativa specific, indica specific. And I've tried both, and I do find there's definitely a difference. I mean, both just as effective, I think, for the tics. But I think during the day, if I'm just relaxing outside, I'd probably take more of a sativa, because it's more, the alertness. You're more, it just kind of, it doesn't have that dosing effective if you would take, again, I'm talking a big amount, if you were to have a large amount. I think the kids, they say indica as they call it indica-couch, right? Because it really kind of has that effect to, so, before bed, I would definitely do an indica more than I would a sativa, just because I find it much more of a sleepy dosing effect if you have a large amount. I was just curious if there was any other information out there.
Interesting. Elia, do you have anything to add?
Well, I mean, it's interesting. It's like what Kirsten shared. Um, I focus not so much on the strain, but more on the compound, the THC content in particular. But I do hear, similar as Peter is sharing, I hear many patients who will, share very strongly that, this strain indica has a certain effect, or sativa, similar to what Peter shared. I think these experiences are compelling enough that they should be studied. It's interesting that it hasn't been studied yet, but consistently. And one of the confusing things is the fact that so much is hybrid now. When we did, and these strains have been bred beyond recognition at this point, and I'm not even sure how easily you can get, the original pure indica or sativa. But when a few years ago we did our retrospective study, basically just asking patients about their experiences, we were hoping to see, okay, we can get some consistent experiences we can put together in terms of the different strains. But people were using all sorts of things that it was hard to make get a consistent story out of it, and things called purple kush, black diamond, like all sorts of things that it was really. But I do think, again, because what it would speak to, the differences, it might not be necessarily just THC and CBD. It might be speak to the differences in other compounds that we don't measure, other things that give the entourage effect that we speak about. So these are things that are definitely worth exploring.
Great. Thank you so much. Now we are coming to a little bit controversial topic, but I guess, it's not, we cannot avoid it because majority actually of people with tics are children. So yes, how about children? Do you think it could be like cannabis-based medicine could be used in children with tics? I mean, I can say that, I have had some teenagers that, I've tried cannabis-based medicine in those, and we published together with Kirsten some case reports about this topic. But as Elia is a child psychiatrist, maybe we start with you. Like, what is your experience? What do you think about this?
Yeah, I think this is a very hot topic right now, because previously, until very recently, there was almost nothing in children other than the few case reports you published. And if you put it all together in the literature, I counted them. They came to you published a review a few years ago, Natalia, I think, together with Kirsten, and you counted them all together. They came to 7 reports. Out of all the uncontrolled studies, it was only 7 that were in the pediatric age group. So almost nothing, but now, very recently, there has just been published a study from Australia, a small study, what they call a pilot or acceptability and feasibility study of 10 patients with Tourette syndrome, but it was a randomized control trial. It was a randomized controlled crossover trial, and it was in adolescents. So their youngest age was 12, so ages 12 to 18. And, I think it had to happen. It has to happen because, we do use it sometimes, in my case, as a last resort. But, I get myself a little bit kind of concerned. But what concerned me about the Australian study is their inclusion criteria, who they agreed to include into the study. So, for me personally, I think if I'm going to have a study with adolescents for using cannabis every day, I'd want to make sure that these are only people who have tried already our treatments for which we have data, and in particular behavioral therapy. And if they've tried them and failed, and then I think it would be reasonable to try cannabis, then these are the kind of patients I would include. But they did not have this requirement in the Australian study. It was quite lenient, the exclusion criteria, meaning that they had patients there who maybe never tried anything else, I don't know, or who never had behavioral therapy. And so this for me is a concern. I'm not saying it shouldn't happen, because again, you could argue, well, would you prefer to have your 15-year-old take, an antipsychotic with its known harms, or cannabis? I think it should at least be something that we should be talking about openly and being very explicit about making this decision. But certainly behavioral therapy. I mean, I think it's hard to argue against a requirement for behavioral therapy as a trial before proceeding with cannabis. Maybe the only thing is one could say, well, maybe the availability of behavioral therapy, maybe it's not readily available. On the other hand, that was a group. It's the group with expertise in Tourette syndrome. I don't know. I would anticipate they would have behavioral therapy available, but I'm not sure. So that's my thought. Clinically, I have used it with kids, very spare. When I would say kids, I should specify teenagers. I've never used it in younger age, but at least I think the youngest was 14 I've ever used it with. And it's really been a situation in all cases. It's a small handful of cases, and all of them, it's been they failed all the other treatments. Maybe I've tried too much to the other things before trying. But and very severe tics. These are not even moderate tics. We're talking very severe tics, even causing physical injury sometimes. And in this small, very limited experience, bless you, Kirsten, or Gesundheit, I should say. The small, very limited experience, I have to say, it's been positive generally. So it is promising. I do think it should be studied in this age group. I think we should proceed with caution. In general, in medicine, medicine is full of stories of, great excitement, and then the field rushes into something only to realize, whoa, this was too much, and then we realize the harm. So it doesn't mean we shouldn't proceed. We just should proceed very cautiously.
Yes, yes, I think it's a great summary. And yeah, to echo this, do you have any, do you remember in this handful of patients, teenagers, what kind of, again, cannabis-based medicine did you use?
Thank you for asking me to clarify, Natalia. So yes, I should be specific here. Because I'm proceeding with caution, I've gone with the pharmaceutical, and specifically Nabilone. And Nabilone even does have indication in pediatric age group, not for tics, obviously, but for other things. And so that's what I've proceeded with, and it's worked. It's been good enough. I don't know, cannabis might work better, probably, but it's been good enough that we haven't had to proceed further with anything else. I have one patient who's now actually a young adult now, and who just turned 18, and we've did Nabilone, and it did help, but it was not good enough. It was similar to the antipsychotics that had been tried before, where they did help, but not good enough, continue to have severe tics despite that. And it was the same with Nabilone. And so I proposed to the family, like actual cannabis, but they are cautious themselves. They are wary. So we're going to see about next steps for this patient. But yeah, it's been Nabilone specifically.
But you have been following up these patients for some time.
Yes.
How long is the longest follow-up that you have?
Maybe not. Well, I'm going to say the longest is probably less than 2 years.
Oh, well, but still, and
Yeah.
it's been well tolerated too in these patients.
Yeah, I have to say, again, cautiously, and so, for those for whom matter dosing, There is the one patient where it worked, but not good enough. We did reach the dose of 2 milligrams 3 times a day, which is a total of 6 milligrams of nabilone. And it did not give additional benefit going to the high doses, but it caused a lot of cognitive side effects. So this is the young adult now that we've titrated him off of it, and we're considering next steps. But with the others, it's been in the range of 3 milligrams total daily dose.
I see. Okay.
Yeah.
Yeah, that's very interesting. And yeah, I must say that yeah, I mean, of course, I agree with you that ideally we should try always behavioral therapy. But the problem, at least that I had several international experiences so far, and I can say that it's a global problem with access to behavioral therapy. Also, and I don't know how it's in other countries, but for example, in Poland, like it has to, like there are restrictions related to finances, like you have to pay it out of the pocket, like nobody will, like the government will not pay for you. So for some people, but the same goes for cannabis-based medicine, at least in Poland. So that's we have to bear in mind this restriction too. But yeah, now, well, I partially know, I think I know what Kirsten will say, but I will ask Kirsten about what is your experience, sort of our shared partially experience, but what is your opinion about this topic? And
so when I started all this research on cannabis-based medicine in Tourette's, I decided first we have to demonstrate that it's effective and safe in adults. And I think although the database is still weak, and including our own study, it was not positive. We failed to demonstrate superior of nabiximols compared to placebo. But I think there were some signals of efficacy in our study, and there's also data from other studies, and all these data show into the same direction. So although the database is weak, I would say we are at this point that we can assume that cannabis-based medicine is effective in Tourette's, and the data also show that it's a safe medication. And therefore, I would say we are at that point that we can start to use it in children in clinical trials. And therefore, I was also very happy to see this first study published only recently. And it would be great to see more data on this. In clinical practice, it's a little bit different. And I would argue when a patient is severely effective and otherwise treatment resistant, I would, independently of age, suggest and discuss with the family a cannabis-based treatment. But yes, indeed, I wouldn't use it at first choice. So I always would recommend behavioral therapy and well-established antipsychotics. But if a family is completely against this, we have to find a solution. And then, but this is an individual decision. I also would be open for cannabis-based treatment. I always have to say, then we have to see who pays for this treatment. And I've mentioned in the beginning, health insurances always ask for a standard treatment first. But as mentioned already, we have some children and adolescents where it's effective, where we see no side effects. These children grew up without any problems. They are good at school. So based on the weak evidence we have, I would say it also might be an option for children. One last sentence, it might be, but we do not know, but we could speculate. It might be that in people suffering from Tourette's, side effects are different compared to what we see in people who abuse cannabis. So it might be that the risk of psychosis is in Tourette patients different compared to people with other disorders or in healthy people without any other psychiatric disorder. But this is only a speculation. And you also can speculate that in Tourette's there might be a dysfunction in the endocannabinoid system, and this would explain efficacy, but it also would go in line with this hypothesis that side effects might be different compared to healthy people who abuse cannabis.
Yes, that's a great summary. Yeah, and we will be slowly wrapping up, but we have one important and sort of related to this age specific questions from the audience. So yeah, I mean, there is a question: how about the risk of age-related dependence on THC? I'm not sure whether I understood correctly the question, but well, we often also talk about generally, you know, the possibility or the risk of course, abuse slow, you know, the longer you use THC, potentially in the literature, there is this discussion about the need to increase dose or abuse of cannabis-based medicine. Yeah, what are your thoughts about this? And the question from the audience, maybe Elia, what do you think?
Sure. I mean, I think it's important to pay attention to the terminology. There's dependence, and then there's addiction. I think what people often are concerned about is addiction, and addiction is when it means you're using it more than you intended to. You're abusing it. You feel like you can't get enough. You're disrupting your life. You're utterly focused on it, and it's impacting your life negatively. So that's addiction. Dependence, it means your body is used to it. Your body has made adjustments based on its presence, and it means if you suddenly stop it, the absence is going to cause a reaction, a withdrawal reaction, and this applies to almost anything we prescribe. Definitely all psychiatric medications, I would say, but a lot of things that we don't think of as psychiatric, as, you know, like if you take a medication for sleep, you definitely cause dependence, but if you take even a medication for constipation regularly, a laxative regularly, you stop it suddenly, you're going to have constipation. If you take an acid suppressant regularly, there's some adjustments your stomach makes, and you stop it suddenly, you're going to have rebound acid stuff. Medication to lower the blood pressure, also your body adapts. You stop it suddenly, you get sudden increase in blood pressure. And so, and then in a non-prescribed stuff, you know, how many of us drink coffee every day? And so and then if we stop it suddenly, we're going to have withdrawal. So if you want to avoid the withdrawal from coffee, you go down slowly. So we have dependence on coffee, dependence on all of these things because our body adjusts to them. And it doesn't mean we're addicted to them, doesn't mean we're addicted to coffee. It just means that there's a physiological dependence. And then so when you want to stop it, if you want to minimize withdrawal reactions, you go down slowly. And I would say the same with cannabis. I do think you can develop dependence with cannabis, like all of these agents I mentioned. I would be surprised if that's not the case. But it's it doesn't mean you're addicted to cannabis. That's a whole other story, and that can happen. But there's a difference. Now, the one more thing I wanted to say, because the question was specifically about age-related dependence on THC. So first of all, we don't have data on that. I don't think we have much data of age-related dependence on anything. Are you more likely to become dependent on coffee if you start young age versus if you start later? We don't have data, but I would think my guess is probably does play a role. If you've taken something since you were a young child for years and years, and your brain has developed and grown in the presence of this thing, I think then you have to be extra careful when it comes to going down, you know, stopping this thing. That's my thought.
Thank you. Yeah, yeah. If you're comfortable, Peter, yeah. Did you notice something like that for you? Did you notice any dependence or that you had
No,
to
I was going to say for myself, yeah, I haven't noticed because, you know, I've obviously traveling. I'm not going to bring anything like that to foreign countries. I don't want to stay as a permanent resident in those countries. So, but, you know, I've taken, you know, when I was using it regularly, I could go away for a week, 2 weeks. I've gone, you know, almost 3 weeks vacation and just stop it in one day. And I don't feel I've had any withdrawals or any, oh my God, I can't wait to get home to take obviously traveling too, you're more relaxed, you're in a different place. The tics were actually subside just because I was away. But it wasn't like I wasn't concerned, or I was like, after I left, like, oh my God, I need to get back home to have some cannabis. Like, no withdrawals, symptoms at all. So
perfect.
Myself, I don't know about others, but okay.
Yeah, but that's very helpful. We are very interested in your personal experience. And yes, Kirsten, yeah, do you have any thoughts on this? Is there anything to add?
So I think it's important to supervise the medication, but it's easy. You can prescribe a specific amount and you have to check that there's no increase. There are some people, in particular those who use cannabis flowers, they sometimes have a tendency to up-titrate slowly. I allow all my patients to use a little bit higher amounts of cannabis medicine when they are in stress. We heard about this, but I also say, okay, there are other situations where you need less, and then you have to down-titrate. And it's not important how much you take per day, but it's important that after 1 month, you have an average dose, and this should be constant. So from day to day, you might have a little change. And this is important because we know from people before we had the chance here in Germany to prescribe cannabis-based medicine. And we know from patients who self-medicated, they often had a slow up-titration. And this can simply be avoided by supervise and control the medication. In the beginning, there's often a little bit dose increase because of this tolerance Elia spoke about, but this is normal, but it's only a few weeks and then you find the dosage. And you should know that the dosage is very, very different from patient to patient. And this is true for all different cannabis-based medicines. But otherwise, I would say there's no problem of addiction or dependency.
Perfect. Thank you so much. So yes, now it's time to wrap up. So my last question as a wrap up for all the panelists, maybe I will start with Peter. What do you think is the most urgent and for you are the unanswered questions, regarding the use of cannabis-based medicine for treatment of tics?
Oh, good question. Yeah, I can't think of anything off the cuff, but I think because I've had a chance to experience with a lot of it. I mean, it was is there an ideal dosing and stuff like that in the future for people? Is it better, to be consistent? Is it better to use it at different times of the day? For me, I find it's possible to use it when you're really stressed and stuff, and other times you don't need to use it as much. But also, I'm in a bit of a different situation now of being retired, so always trying to reduce the amount of medications if possible. But yeah, it's nothing specific unanswered at this point. I kind of have good knowledge using it, how it's effective and so on. So
great, thank you. How about you, Elia? What are the most urgent questions in your opinion for the field?
Yes, I would say, I mean, there's lots of questions, but if I have to pick for me, the number one is what we were discussing just a few minutes earlier, which is in the studying this in the pediatric population. And so we've had the very first study that was published out of Australia very recently, but I think there's much more to be studied there. So that's the very first. The other is a long-term follow-up with regards to psychosis. And so, having said that, I want to say that there's a lot of the medications we prescribe that have not been studied enough long-term. So long-term studies are always needed, but including in cannabis, and in particular to see about the risk of psychosis long-term and the role of age in the risk of psychosis. And then if I may squeeze in a third one, the third one is just something that Kirsten touched on earlier, which is the lack of data on comparing the different products that we have, like oral versus inhaled. That's an administration, but also the products themselves.
Oh yeah, so these are actually very similar to mine, my top ones, because I'm also think that we really need more studies in pediatric population if possible, of course, with its limitations. But and then yes, the need to to compare different substances, because still we are not sure. And for the third one, top for me would be like which type of patient actually Tourette patient would be benefit the most. So sort of like a personalized treatment. And for you, Kirsten, what are
There's
your...
nothing to add. All important points are already raised.
Great. So then I would like to thank you, the participants, first of all, our great panelists. I think it was a very fruitful discussion. And Peter, really thank you so much that you also dedicated your time and shared your experience. I think it's really unique. I've been to a number also of events dedicated to this topic, and it's great to have you on board too. Thank you, Kirsten. Thank you, Elia, for your great insight and your expertise and your time. I know that you're very busy, and thank you very much also for all your questions and people who participated, and the patient who shared his or her, I'm sorry, I still don't know, expertise and experience with cannabis-based medicine. Thank you, TTAC, for having us today. And yes, have a lovely weekend, everybody, and join other events organized by TTAC and ESTS. I will use this platform to advertise our Congress, upcoming Congress in Athens in May. And yeah, see you. I will see you around. Thank you so much.
Thanks,
Bye-bye.
everybody, and thank you. Thanks for all your research and everything you guys are doing. So thank you.
Thank you.
Thank you, Natalia,
Thank
for
you.
the nice
Thank you.
invitation.
Bye-bye.
Bye. Bye.
Bye bye, everyone. Thank you.
Bye.